Welcome to Health System CIO's interview with Dr. Patrick Woodard, CIO at Monument Health. I'm Anthony Guerra, founder and editor-in-chief. Dr. Woodard, thanks for joining me.
It's my pleasure to be here. Thank you.
All right, great. You want to start out by giving us a little bit about your organization and your role?
Yeah, happy to do so. I'm Patrick Woodard, as you mentioned. And again, thanks for having me. I serve as the Chief Information Officer for Monument Health. We are a regional community-based system in Western South Dakota, serving 5 states, Western South Dakota and North Dakota, Western Nebraska, and then Eastern Wyoming and Montana. I've been here about 2.5 years, and it's been probably the most rewarding 2.5 years of my career. I am a physician by background, but one of the reasons that I particularly like Monument Health is because it's a community-based system, and we're the only one in the region. It really kind of puts a stamp on the importance of our mission in serving these communities. If you aren't coming here, you got to go, 6 hours out of your way. And for some people, that might mean a life or death scenario. So really kind of drives home the importance of being a high quality, reliable, technically sound institution. And I'm proud to be part of that.
All right, very good. So you've been thinking a lot about AI as everyone else has been. Your thoughts on it have been very interesting. This combining of man and machine, comments about a different type of leadership, a different way to approach the job, as it were, of CIO. And so I'd like to hear more from you about sort of where your mind is right now. Um, you're obviously trying to figure out how to leverage the things that are happening out there to the best advantage of the health system and the patients and the caregivers. What's your latest thinking on some of these major dynamics going on?
I think the place where we've thought about it so far has been this kind of back office or middle office. And there have been a couple of advantages that we've taken advantage of over the past, let's call it a year and a half. The ambient listenings, the abridges of the world, the Suki, the NAMBLA, or NABLA, the nuance, all of those are out there and changing physicians and providers' lives in a clinic. But they're not agents. They're a documentation tool. They're kind of like, if you remember back to November of 2023, when we all got access to ChatGPT and we were so blown away with what it could do, it's the same thing, but for the exam room, which is important, right? I mean, we're having real benefits. We're seeing doctors be able to go home and have dinner with their families, something that they maybe haven't done in their whole career. Maybe they're seeing an extra patient in the day, or maybe they're actually just like having a face-to-face interaction with their patient. It's not groundbreaking. I mean, it's great for sure, but it doesn't completely change the way that we deliver care. And it doesn't change the labor pool required. You still need a doctor there. And where I think we need to be going as a institution, as an industry, is thinking about rethinking, like, what does labor actually look like? We've for years been talking about everyone needing to work at the top of their license. It's almost a meaningless phrase at this point, right? We're asking nurses to work at the top of their license and doctors work at the top of their license, which is another way of just saying, don't do meaningless work, which I think we would all love to get rid of meaningless work. But how do you quantify what that is? I mean, there's probably, I don't know, 400 different pieces of meaningless work that you do throughout your day. And what we really mean when we say work at the top of your license is have somebody else do that. I think we're at a place right now where we can say, well, we need to start be thinking about, like, instead of having somebody else do that stuff I don't want to do, maybe I just don't do it. Maybe nobody does it, but it still happens. Maybe it's an agent that's doing it. Maybe it's an AI agent that's doing it, or maybe it's completely automated out of the system. And so I think there's a bit of an obligation for at least technical leaders like myself, but I think also our operational leaders, to be thinking about what are the ways that I can be thinking about how we work much more than what work we do.
Yeah. Do you think about, and you may have mentioned this, but do you think about, does it need to be done at all? Right? If we can automate something, but then even beyond that, do we even need to automate this thing?
I think it's a really good question. And, I came from a lean kind of background from the startup community before moving on to the health system side of things. The lean team is part of our team today. And a lot of the questions that you should be asking when you're doing any kind of workflow readjustment, whether that be through a new implementation of technology or through a lean workshop, is, to your point, is there something that we should be doing at all? We digitized for so many years, right? I mean, when I was in residency, we were training on paper, which was unfortunately not that long ago. And what we did with EMRs largely was take a paper process and digitize it. There's, I think, now an opportunity for us to move away from this digitization mode and into a transformation mode. And that does, to your point, really require us to ask the question, do we really need this at all? Most of it we don't. And I think if you go ask any physician, just pull a random physician out of a clinic or the floor, they'll tell you that probably 80% of the stuff that they do doesn't add any value to them for sure. And maybe another 80% of that doesn't add any value to anyone. But it's required for billing or it's required for all of this other stuff. And maybe that's still going to be true, and that's fine. But if nobody sees it, then it's like if the tree falls in the forest, does it make a sound? If you've automated all the minutia out, does the minutia even exist anymore? So maybe you can think of it from that perspective.
Right. So make sure we're not just doing things that are totally meaningless. Work on automating the things that we can leverage the tools. I wonder, we've got this dynamic here with AI where, as you said, the large language models working brilliantly for this particular use case, which is digitizing physician notes, summarizing notes. So it works amazingly well for this really important use case. And so we've got this hammer that's really good at hammering in a nail, and we're like, what else can this hammer do? Right? And so we're looking around, we're like, it's amazing at this thing, but what else can it do? And I wonder if we're just struggling here a little bit. It reminds me of, we saw blockchain doing amazing things with Bitcoin, and we go,
Yeah.
that's amazing at that thing, right? Everybody's, well, it's got to be amazing at other things. Well, but it wasn't apparently. Like, it's really good at the thing it's doing. I don't know if you feel like we're gonna see more limitations or more struggles than we thought at the beginning when we thought this hammer can work on everything.
Well, I think we probably should make a distinction because we say AI, but when we say that, we should probably ask out loud, what do I mean when I say AI? What do you mean when you say AI? And what do they mean when they say AI? Because we've actually been doing AI for years. I mean, the first EKG computer-based read of an electrocardiogram was in the 70s, and that was an algorithm. So, I mean, you could call that AI. It was a computer reading something that otherwise a human would have had to read. So that's automated, that's AI. More recently, before the advent of publicly available LLMs, you had predictive models for deterioration for patients in the hospital or a risk of no-show for clinic visits. And that's AI, it's a predictive model. And then you have LLMs, which are still prediction machines, but one in a way that works completely differently. So I think we have to be careful of saying, like, if we want the AI, which is there is no such thing. There's many different AIs out there to do one thing. I think you're right. Like, one hammer is not everything is a nail. If you have a screw, it's not a great day.
Right.
But if you think of AI as a tool chest, and there is a screwdriver and there is a hammer, I think it is a tool chest. Now, I also don't think that there's a tool for every single thing in there, and that's why I think we need to go back to, not that I think that we want to go through and ask everybody to catalog every single thing they do every day. That would be an awful task, but it'd be interesting. And of those, and maybe you ask AI to categorize what could be offloaded. What do you not have to do?
Hmm.
I mean, the lean idea of time studies and seeing how people work and what they're spending their time on would be a useful exercise if we were willing to undertake it. Because I think there are plenty of things where, with the right knowledge of the vast array of tools that exist in the AI toolbox, maybe there's one for this use case and a different one for another use case. I think there will be an integration challenge that IT teams like ours will need to tackle at some point. But I think that's a challenge that we'd be very anxious to undertake.
So that's a really interesting point, and I think this is a big issue when it comes to AI and workforces. We've got tools that are doing amazing things that can do amazing things, and that's changing every day as they get better and better at what they're doing, and they can do more things. We've got a workforce who's every little step we don't know, every little challenge we don't know. So how do we take that? How do we get that knowledge of what can be done and what's possible based on the tools almost in a real time or as close to real time as we can get, and expose our users to that so that they can figure out all the little nooks and crannies of their workflow and they can do the matching up, right? Because that's part of the game. It reminds, I thought of the example this morning as I was getting ready for our talk. It's like when you've been doing something on your computer or an application you use every day, and you've been taking 6 clicks to do it, and somebody happens to look over your shoulder and see and go, "Oh, did you know you could just click here?" And
Hmm.
you're like, "Oh my God, for 5 years I've been doing it this way." So that to me, I think a little bit about AI. I think that so much of the work people are doing, they don't even realize this can help with it, but it can. And so we need to match that up as quickly as possible. What do you think about that dynamic?
That's a problem as old as time, for really. I would say even with our EHR, we work with the company out of Verona, and one of the things that they released recently was kind of a utilization score of what we were doing within the EHR.
Mm-hmm.
And like a lot of, we were solidly in the 50th percentile, but our utilization of all these like advanced tools that we have um, was like in the, low 30s
Yeah.
percentage wise.
Uh-huh.
So these are not things that are highly advanced. And then you go on the Gemba, you go to the front line, you watch what people are doing, and you ask a nurse. So there's an electronic, it's called a brain, and it's where the nurse can keep his or her notes within the EHR. It's kind of a task list. It's like vitals, medicines, things that you want to remember about a particular patient. And for years, decades, probably, maybe even centuries, it's been a piece of paper that you kind of write down everything that you need to know to manage your patients.
Yeah, yeah.
Well, that was digitized along with everything else several years ago. And then you go on the floor and you see that people still are using the paper brain, and you say, well, why don't you use the one that's in the EHR? And they give you a smattering of reasons, some of which are legitimate and some of which are just, I don't want to change. But without knowing what people are actually doing, like seeing it and
Yeah.
going elbow to elbow, it's almost an impossible task, because how do you like, I can put out a training PowerPoint or a video, or we can do an at the elbow training, but as soon as you walk away, if they don't like it, they're going to go back to what they're doing before. So you have to really demonstrate the value. A lot of our technologies haven't demonstrated value to an individual. They
Right.
serve a different purpose, right? Maybe the value is to getting paid by the payer. Maybe the value is moving patients through the system faster so that you can improve your throughput. But for an individual nurse, moving patients through the system is better for the patient, but might actually increase that nurse's work. So how do we tell every story as a value story for each individual? The what's in it for me is not going to be less important in the age of AI. I think it will be more important, but I think there are more opportunities to tell it in a way that makes sense. Our ambient solution sold itself. We like
Yeah. Yeah.
it truly did, because it's an immediate value to the clinicians who are using it. And whether you can justify the expense on the back end, that's my problem. But if I can create the opportunity to really improve people's lives through a piece of technology that we can easily implement, then it will sell itself. And so we have to find the nuggets of value in everything that we're doing. I mean, we probably should have always been doing that, but I think we have an opportunity to actually start removing some of the nonsense that we've been putting on people through the thoughtful implementation of AI agents or other automations, much more so than we've done in the past, which has historically just been adding additional stuff.
Right. Right. Absolutely. You mentioned justifying the expense on the back end, so that's an interesting issue. Um, we're in this interesting situation where the stuff that the licenses for the ambient listening I've heard are very expensive. The ROI is not a hard ROI where you might
Oh,
find in revenue cycle management or something like that. It's not a hard ROI, but it's almost everybody says it's an obvious ROI in terms of the benefit to the physicians. Is that good enough to justify the expense, or is it still, as you said, that's your job? Is this part of what you have to do to figure out how am I going to demonstrate an ROI on this when it's a little more complicated, but it's so obvious to anyone who speaks to these physicians that they're just way happier?
yeah. I think first of all, it is our job as technology leaders to justify really anything that we're doing. We shouldn't probably just be doing willy-nilly, and which is not to say like don't explore, don't iterate. You should do those too. Not everything is going to generate an ROI. And more importantly, in healthcare, many things will not generate a financial ROI, but you may have a physician satisfaction return on investment. You may have a patient quality satisfaction or a quality benefit or a satisfaction benefit there. And sometimes you just have to accept that as a cost of doing business. But if everything is just a cost of doing business, at some point, then you can't actually do anything, right? I mean, at some point, would you rather have happy physicians or a new MRI machine? Like, I want both, but the budget's not unlimited. So I want to be able to continue to provide high quality care. I think that's generally the North Star, and to be part of this community. But I think you get a freebie the first one because it works really well. Everybody's really happy. The next one that costs the same amount of money, you're right, they aren't cheap. It's going to be incrementally harder. And then the one after that that doesn't have a hard ROI will be incrementally harder. And so from that perspective, I think we have to be a little, I think it is asking us, the situation is asking us to be more planful about what are we doing and why. So I like to think about it in terms of how am I tying this to our strategy? One of our 5 pillars is be a great place to work. And as part of that is that you have tools that make it easier to do your job? Is it part of enjoying your colleagues, being able to have people that you like working with? Is it not having to do meaningless tasks? I think those are all ways that can make it a great place to work. So if I'm able to tell that as part of the story to justify what we are implementing, then it's I think a little bit easier for the my peers to understand, for a board of directors to understand why are we spending money in this area? Well, it's aligned to our strategy, and here's how it's aligned to our strategy. At the macro level, at the individual level, you still have to go back to what's in it for me, and why would I want to listen to you about this? And you have to, and we should prove it, right? If we say it's gonna save you time, let's prove it and have it actually do that.
Mm-hmm. Yep. Let's talk about the dynamic of I think of it as a street where traffic goes two ways. One would be you bringing ideas to the users, so to speak, based on technologies that you've seen evolving or you know about in the marketplace, and saying, I know you guys have these challenges, and here are some tools that we've come across that may help, versus the requests bubbling up from the users. We need this, we need that. So sometimes you're the one that's bringing the technology as a suggestion to the users. Sometimes they're the ones requesting technologies. I guess you got governance laid over this whole thing to try and figure out. And we're going to do a webinar on this because I think it's probably one of the most important. It probably could be the most important thing you do in your position, which is how do I match up or how do I make best use of the resources in my department, my budget, my people. I can make a certain size pie with all this stuff I have, but the request is a much bigger pie, right?
Sure.
It's always
Always.
bigger
Yeah.
than what I have. So how am I going to use this to match up and keep everybody happy as much as possible? And they're never going to be happy because somebody is not going to get the slice of the pie they wanted because your pie is smaller. So that's a huge part of what you do, right? Doing that in a appropriate way that matches up with the strategic goals to where it's transparent and people aren't screaming all the time at you, right? I mean, this is a big part of the job.
Absolutely. It's what I spent my first year and a half working on, frankly. I've been here 2.5 years. I think we're in a good state now. But we had to kind of flip the whole thing on its head because, to your point, it was kind of this black hole of a bunch of approved things that lived on a wall someplace that no one really knew where it was. And there were things from 7 years ago that were approved, but nobody was working on, which is not really a dig on anybody. This is very common. So, and it's a challenge. We took the approach, and we could probably do a whole hour on just our approach to governance, but we took the approach that it should exactly mimic any other organizational governance process. Technology is, I guess, has a department, which many things don't necessarily do that are org defining, but it's really part and parcel of every single area. Like, you can't do anything in healthcare anymore without some technology, and it has to be connected to some network or connected to some server someplace or whatever. And so there's really almost nothing that you want to be able to do that doesn't involve that. So we don't think that it should have some sort of separate governance process. It should follow the same governance as everything else, which for us is fully managed by the business. We participate, of course, and I do have a vote. It carries no more weight than anybody else's. And by fully being transparent about the resources that it will take, both in terms of labor and in financial resources, and then when generally compared with everything else you may expect to get it, we've really gotten a good handle on that. I think to your earlier point about how do you balance what do I bring to the business versus what does the business bring to me? I think it requires a lot of listening on both parts. I generally view my job as a chief listener, and which is not to say that all I ever do is just go like eavesdrop on people's conversations, although there's maybe a little bit of that. But it's really trying to understand what are the problems that they're trying to solve and try to internalize that so that if I hear that my finance team has a trouble with labor shortage in AP, I don't necessarily need to go out there and be hunting for a particular solution for that. But if I hear about something that might help with that, then let me bring that forward as a partner and as a trusted partner. And conversely, if someone's bringing me a tool that they see, I'm open. I want to learn about it all, right? Because I need to know what's out there. You couldn't possibly. I mean, there's entire marketplaces devoted to trying to understand the entirety of the world. I don't know how a single person could do it, but you do want to kind of learn more. And then I think the question that you follow up that with would be, well, this is very interesting. What other tools have you looked at, and what is the particular solution you're trying to solve for? And then by asking that question and trying to more deeply understand what the frustration is that's driving the request, maybe the tool they picked is the right one. It could very well be. Or maybe there's an opportunity to bring your technical expertise to bear and help them solve their problem in a way that they maybe hadn't thought about, or something like that. Which I think just goes to partnership. You must partner. You have to be trusted as a peer and as an expert, but also one that's willing to more want to deeply understand what their day-to-day life looks like, because they have the things that will frustrate them to no end that you may never know about if you don't listen.
Yeah, very good. Um, so you're a doctor, and we've certainly seen evolution in the CIO role where there's quite a few MDs now in that role. The way we've also had a huge explosion of IT related C-suite titles in health systems. It used to probably be two or three, and
Yeah.
I think you certainly could be up to seven or eight in the larger health systems. Um, and my thought on this is that what you want is you need an assortment of knowledge or skills in in that C-suite, and it doesn't really matter how you have it split up, but you need people who know sort of deep technology, infrastructure, network, cybersecurity. Um, so some of those heavy technology things, and then you need someone certainly like an MD or somebody who understands clinical workflow, and you have to have all of that but it could be split up in any number of ways based on titles. So, you've got the clinical expertise. So when you were taking on this role, did you want to make sure you had a strong CTO? Because, that's probably not your wheelhouse. You like, I maybe don't need a CMIO who's got 20 years of experience because I'm a doctor, but I really want to make sure we're stronger in the other areas where I could really lean on someone for some of this stuff. Did you think of it that way? And does that make sense to like say we need these certain skill sets? We can split them up however we want.
I think that's fair. And maybe I would go back by talking about my experience as a physician. I'm an internist first and foremost, and I practiced as a hospitalist. And as an internist, you're required to know about many things about
Mm.
a human, how things work and how they break. And it doesn't mean that because I know that you have a hip fracture that I'm going to be the one to go into the OR and do the surgery. And trust me, you don't want me to. It's not like House. Like House does everything. He's a great credit to him, great doctor, but he does a little too much. But I have to know who to call and when to call them. I have to know what things I can manage myself. If I call a cardiologist for every patient with atrial fibrillation, they're going to stop taking my call because I should be able to manage some of that myself. I would liken the CIO role to that of an internist, really, is understanding what are the things that I can and should manage myself, what are the times that I need to call a consultant for, and who are the consultants that I do want to call. I think to your direct question, I think it extends beyond just the IT technical teams as well. If let's say I was the best technologist in the world and I'm a decent physician as well, if I can't go then sell an idea to the CFO, we're not going to get very far. So I think
Yep.
the role really requires that you really are well-rounded enough in enough areas that you know who to ask to help, build out a performa. And maybe you get one started and you have one that's 85% of the way there. And then you don't feel bad going to sit down with your CFO and saying, or your VP of finance and saying, hey, what are some parts that I'm missing in this performa? Let's work through it together. It's worked pretty well. They kind of like it when you ask them for advice. Same with your technologists. Like I don't go to my networks team and tell them like it would be a bad network. So yes, you do need the expertise within the house, but I also do have really strong physician IT leaders that could stand on their own. They don't need me to be a physician either, and I wouldn't want to presume that I should or could replace any one of my leaders. Like if you took me out, that leadership team doesn't need to change at all just because I get swapped out. And that team, I think, in my opinion, should be as well-rounded as you want to be, because, you know, we focus in different areas. I'm trying to think about where are we trying to be 3 or 5 years from now as a health system. And I'm asking my direct reports to be thinking about where we should be a year from now or maybe 2 years from now. And sometimes it's what are we doing today? If I spend all my time in the what are we doing today, I don't think I'm doing our health system a great service. But if I also don't know what we're doing on a day-to-day basis, I also don't know that I'm doing the IT teams any service either. So I think you just need to pay a lot of attention, but focus on creating a well-rounded team that should be able to stand on its own without you, much more than focus about filling in your weaknesses. Ultimately, you're also thinking about your succession plan. What happens when I'm leaving? And if you leave, because eventually you'll retire, even if you don't leave the organization. And if you're able to leave a really solidly functioning team that doesn't have any gaps, man, how great would that be to come in and pick that up as a
Yeah.
future leader?
Yeah. That would be nice. So you mentioned your role, is no one else is looking at that 3 to 5 year outlook, right? There are other people focused on day to day. That's your job, right? You're supposed to make sure that, if we take this ocean liner tanker analogy,
Hmm.
you're the captain and the things doesn't steer at the last minute, right? So we want to make sure the tanker's going in the right direction. And do you feel like uh, catching this AI stuff right and making sure you're following it as things change and that you're leveraging it or trying to inject it into your health system to the greatest benefit of patients and users. Do you feel like that's kind of your number one right now? Because this stuff's going to move so fast and can be so impactful.
I do, but with a level of caution, because to your earlier point about blockchain, nobody's talking about that much.
No, no way.
There's something that feels different about this particular movement around AI, and I think it's because there are, and I would go back to there's, we say AI kind of as a global catch-all phrase, but we're talking about a multitude of technologies at various maturity points.
Right.
If you're looking at predictive models, some of those are quite mature and are way out in terms of that plateau of success or whatever it's called in the Gartner hype cycle, right? Some of these others, like LLMs, you know, I think are still fairly immature and are very hyped. I do think that there will be plenty of back office opportunities for those to be successful and perhaps some front office ones as well, you know, in the clinical arena, um, as long as we're doing it carefully. I think there will also be a graveyard of tools that had a lot of promise that just never quite got there because of too high of an error rate or inaccurate AI governance at the health system level, things like that, that just weren't able to push it into the value equation. So I don't think that we can, I think there's an the AI tools now have reached a level of maturity from a data perspective and from kind of a predictability perspective that there's a lot to build on. But I would actually liken it much more to the early days of the internet than anything else. You know, where we didn't know PayPal didn't exist when was PayPal created in the late 90s, I think, or early 2000s,
Hmm.
that you could have an entire financial platform that was built entirely on the internet to be able to move money around. Before then, you'd have to like go to the ATM or wire people money and or like I figure out how to
Hmm.
send them a credit card number. I think the next generation of tools that will transform the way that we interact as patients within a health system or clinicians within a health system or clinicians to patients, maybe are just being created right now, and we won't know about them for 3 to 5 years. So I do think it's important to pay attention. I would be very cautious about placing my eggs in any baskets, though.
Yeah. It is sort of what's the dream state here? And when I just quickly think about the dream state, it would be, my genome totally sequenced, right? So you know me from at a genomic level, my symptoms input through different wearables, right? So I've got symptoms and I've got wearables on. So you know about me now.
Hmm.
You got my genome sequenced. You've got my EMR, like from everywhere I've ever been and every doctor I've ever seen, and that's all in there. Like put everything in a blender, right? You're putting this all in a blender, and then you've got the global world history of medical literature, verified and all that. So now you're matching up what's going on with me versus my history and my genome with the best knowledge that human beings have put together, and out spits, here's what you do to Anthony today, right? In a millisecond. Is that make any sense?
Yeah, I think that works for a decent number of individuals. I think the challenge is that you are a more opt-in type person, right? You're saying like, I want my DNA out there. I want to wear wearables. I think there are plenty of other folks who say, I don't want anybody to know about I mean,
Right.
look at Europe. They enshrined the right to be forgotten. The people
Yeah.
who want to be forgotten in the EU probably don't want their DNA living someplace, and they don't want to connect all their data.
Yeah.
Um, Unfortunately, or fortunately, depending on how you look at it, health systems have the opportunity to care for both of those people. And what we need to be careful about doing is not creating two different systems of quality. I don't want there to be a haves and haves not of health equality, where the people who've opted in and don't care about privacy and love sticking stickers all over their body to follow everything because they can afford to buy every off-the-shelf commercial um, tool or consumer-based tool. I don't want them to end up being generally healthier than the people who want to maintain their privacy. I think we have an obligation as, I mean, I took an oath to care for people. And the first is to do good, and the second is to do no harm, or maybe it's the other way around. Either way, we're doing good and we're not doing harm. But if we're not remembering that we're building for both, then I think we are doing a sizable portion of the population a disservice. I'm with you. I mean, I think privacy's been dead for a long time, so who cares about whether my DNA is out there? And I'd love to be able to have a higher level of accuracy for our diagnostics and all of that. But we also have to remember there are a lot of low health literacy folks out there, a lot of folks who don't have access to the same financial resources that we might. And our obligation as health system leaders is to make sure that we're caring for each one of those people equitably. And we have to build our systems in a way that enables that to be true every time and not just when the opted in people are coming in.
Yeah, that's true, and we don't need to get like too far off of technology, but patients do have a responsibility to participate at some level, either in giving you access to their bodies, right? Or cooperating with your advice and prescriptions and do this and do that. And you're limited sometimes in your effectiveness by their willingness to participate in the care as you've outlined it. So that's always a challenge, right?
It is, and we also have to remember there may be people who are theoretically willing, but have some sort of debilitating condition that prevents them from being able to do so.
Hmm.
If they have advanced Alzheimer's and can't remember to follow your advice,
Of course,
we're
of
not just be like,
course.
sorry. Yeah.
No.
So, I think it is important for us to think about as we engage and opt people in, what are
Mhm.
the ways that we can create equitable technology opportunities for everyone who will walk through that door. And maybe there is an obligation. I don't know where that lies,
Right.
ethically or societally, on a health system or a community to provide. Let's say we discover that continuous glucose monitors are the number one predictor of cancer or something. I'm making this up clearly.
Yeah.
But I think a lot of us are going to go rush out and just buy a supply of continuous glucose monitors. But there's a lot of other folks who'd benefit from the same treatment. And then I think we'll probably have to have a societal discussion of, well, we're willing to pay for, people that have Medicare Part D,
Hmm.
or, with some supplementary costs and what have you. Are we now also going to have let's call it Medicare Part E, which is, the technical elements that may benefit health? Things like that we probably should start considering, because there will be some technical things that occur, technological events that will occur that have positive direct health outcomes on large swaths of people. I think the good analog in pharmaceuticals are all the GLP-1s for weight loss. If we paid as a society for all of those for everybody, we would bankrupt ourselves.
Yeah.
We haven't really solved that problem yet either. So we should have that conversation first, and then also think about how can we create a series of reliable rules that apply to technology outcomes as well. I think, to go back to your question of what does the future look like, um, yours, I like it a lot. Sort of, because you didn't have a role for me as a physician in there, right? There's a lot of like automated stuff, which is great. I also think, as a patient myself, um, I can use the tricorder, but if I'm getting bad news, I'd like it to come from a person probably. But I also don't want the only time a person to walk in the room is when I'm getting bad news. So I think we need to keep the human in the exam room for at least a while, because even though the LLMs tend to be a little bit more empathetic on an individual basis, I
Yeah.
think it's still nicer to have it coming from a human, at least for now.
Well, I'll tell you though, they're not perfect because I created this it's supposed to give me a notification when certain weather conditions are met to tell me if I'm gonna gotta put my sprinklers on.
Oh yeah.
And this morning it said, uh, you need your sprinklers today because the high is gonna be 88 and you didn't get half an inch of rainfall yesterday. All these parameters I put in. And I'm like, the high's not gonna be 88 today. I'm like, the high's gonna be 69. So I wrote back to it. I said the high is going to be 69, and it basically was like, "Oh yeah, sorry." So it's like,
Well, good. There's still hope for us after all.
yeah. I definitely still want you in the room, Dr. Woodard. So, listen, this was, let me ask you one final question. I'm going to let you go. Final piece of advice for someone in your position at another health system, based on your experience so far, everything going on, things that you feel are helping you stay on track and be successful. Best piece of advice.
Listen more everywhere. And that is in your own system. It's on the Gemba, it's on the front line, and it's to, webinars or conversations like these. It's, I shouldn't say this in a public setting, but I do read every email that I get. I quickly delete most of them, but I do read them all because you kind of need to know what's out there. And just because I see the first lines, I probably know that I don't want to read the rest of it. But if it's truly interesting, don't email me more. I don't need more email. So whoever's listening, I don't need more email, but I do read them all. So
That's great.
I use that as a listen more opportunity, because you never know what the thing that might actually improve will be. And it'll be from your front line for sure.
Yeah,
And there may be something that you just haven't heard about yet out there.
I love it. All right, Dr. Woodard, thank you so much for your time. I hope we can catch up with you down the road.
Absolutely.
Have a
Great to see
great day.
you.
Bye bye.